Welcome back to Journalist Roundtable. I'm Kent Davey, the moderator tonight. I'm joined by Allison St. John from KPBS and Tony Sagala from the Coast News, managing editor. Our next guest is Chris Van Gorder, who is the CEO and president of Scripps Health. Scripps Health is a remarkable institution in North County, San Diego County. It's been named one of the top 15 hospitals by one of the rating services, one of the 100 best places to work in America. Is that generally America generally or American hospitals? I wasn't quite sure.
No, it's all industries.
All industries. With that, Tony, would you like to start us?
Sure, yeah. Well, if you could start us off by maybe describing a little bit about the hospital industry environment and how it is here in the North County.
Well, from a national perspective, we're probably facing the biggest challenges we ever have, and I've often said 100 years. We are, healthcare nationally is too expensive. It's become unaffordable. There are too many people that lack access. And I think that was what drove the Affordable Care Act to be put in place. But to pay for the Affordable Care Act, reimbursement is being reduced fairly dramatically. The industry gave about $150 billion to help pay for the Affordable Care Act, so we're actually seeing declines in reimbursement for Medicare. Medicaid and Medi-Cal in California is very challenging. And then we got hit with sequestration. So just my organization alone got cut another $12 million a year. So we're facing increasing costs, decreasing revenue, but a need for us to completely redesign the healthcare delivery system so that we can serve our community and be more affordable to everybody in this country.
So is the way to deal with this to become larger, to have fewer larger healthcare providers in San Diego? And if so, are you thinking about how you could expand?
Well, I think what we're going to see is an expansion, certainly, of the ambulatory care. Our system was really started as a hospital system, and hospitals have been the hub probably historically in this country, but they're not going to be in the future. I think what we're going to do now is we're kind of flipping the model. I often say that we're a sick business. If you're not sick, we're out of business. And that's because that's how we're compensated in this country. I think we're shifting the model now to where we're actually going to be compensated to keep people well. And I actually think that's the best thing that's ever happened in healthcare, because instead of just waiting for somebody to get sick, we're actually going to build ambulatory sites and integrate a very fragmented industry together to create really a healthy environment for patients and a lower cost environment for patients. So to answer your question, I think it's going to be very challenging for it's going to be challenging for everybody, but particularly challenging for freestanding hospitals to survive when reimbursement is declining, okay? They have to shift really to an ambulatory environment more than a hospital environment. You have to gain economies of scale to be able to do that, be fully integrated with physicians to be able to do that effectively, and systems are usually better able to do that than a standalone hospital would be able to do it. So I think we are going to see consolidation of the industry. And we're going to see larger systems, be that regionally, in some cases nationally.
Should we infer from your comments that the reimbursement model is going to change more from a fee-for-service, individual service, more to a capitated basis where you get paid for taking care of the whole patient?
Yeah, it'll vary across the country. There's going to be environments like California and San Diego that will probably embrace that model faster because we have a large presence of Kaiser. Sharp has historically embraced that model. We're starting to embrace that model. And so I think what you're going to see in San Diego is more population health reimbursement, which is not exactly fee-for-service, okay? And that, again, what I said is probably the most effective reimbursement methodology to pay us for keeping people well is capitation, where you end up getting a per member per month reimbursement. Then you're economically motivated and clinically motivated and community motivated to actually do everything you can to keep people well and treat them closer to their homes in less expensive settings and do what's appropriate for their care and not just everything that everybody wants done.
The near and dear to people in Oceanside has been the existence of TriCity Medical Center. Historically, there has been some, with at least past administrations at TriCity, some wrangling between Scripps and TriCity. I was at a panel moderated a panel discussion several months ago in which someone from Scripps was part of that discussion. There was certainly some talk then about perhaps there's a possibility somehow of TriCity and Scripps finding a path, or someone else. Does that fit what you said about it's just very difficult for us, for a sole independent hospital?
You know, we're in a funny business. There's competition and there's collaboration, and sometimes it's the same thing. For example, we have done all of Kaiser's heart work for 30 years. So Kaiser is clearly a competitor, but we collaborate in heart care. Our Proton Beam Center is a collaboration between Scripps and UCSD and Rady Children's Hospital.
Which is new, by the way.
Brand new, brand new. So we have all sorts of collaborations around the community. Probably 12, 13, 14 years ago, I actually reached out up here and said, hey, look, if there's any way you want to affiliate, collaborate, there's all sorts of things short of actually coming together and merging that we can do to collaborate. In fact, recently, the interim chief executive came down and met with me, and we had a discussion about what we could do. And there was actually a small piece of work that he said, you know, is it possible to bring that back to TriCity? And said, done. We made it happen. So I'm very optimistic that what we're going to see in the future is a much more collaborative relationship, and certainly not one where we're going after each other and suing each other and doing those kinds of things, because it's just not constructive in the environment at all, and generally not what hospitals do to each other.
Do you see a need for a hospital in Oceanside?
Absolutely. Absolutely, unequivocally. In fact, every existing hospital in this community is needed right now. We can't afford to have any more closures of hospitals. So I think we're going to find a way of working closer together. But we've studied the environment across the entire county. We don't need to add beds, even though the population is going to increase, but we can't afford to lose any beds. So TriCity is an absolutely critical hospital, and it needs to survive and serve this community without a doubt.
And you can go ahead. I'm sorry.
Well, so, I mean, TriCity is a little bit different from Scripps in the sense that it has an elected board. It's a public hospital, and you know, there have been some questions about really whether that's a viable model for running a healthcare system anymore. Would that be a hindrance or a stumbling block to you cooperating, do you think? I mean, could you cooperate with it still having an elected board?
Absolutely. I think there's a number of examples, and certainly Grossmont is probably the closest example of being part of a larger healthcare system, and yet the district still exists, still has certain controls over the hospital, still is representing their community, and doing, I'm sure, outpatient work and a variety of different things still in the community. So I think actually the model can work very well together.
Changing the subject just slightly, one of the criticisms of the Affordable Health Care Act as it started to roll forward in time was a concern that as uninsured came onto the new roles of insured, that there would be a significant shortage of primary care physicians. Are you seeing that? Is that a real concern, at least here in San Diego?
You know, I was asked that question probably, 50 times, in the years after the Affordable Care Act was passed and implementation, and I said I never actually expected that it'd be this huge volume of patients all of a sudden, and we haven't really seen it in the emergency rooms, and as far as I know, we actually haven't seen it on the primary care side as well. A lot of those patients were still getting their care taken care of. Now, be that the community clinics that they were getting their care, the emergency room, they were getting their care in many cases. So there may be some delays in getting your initial appointment, but I haven't seen this, huge blip of patients not being able to get access. Probably the bigger challenge these days in the exchange is the narrow networks, where people have signed onto the exchange and found out that their doctor or their hospital isn't in that narrow network. I think that's a bigger issue than new patients newly insured.
Okay. As you look forward, as healthcare technology starts to change, how much will technology change due to medical care, what it has done to industries, say like the newspaper business?
Yeah. That's an excellent question, and I think we have to harness, we're 20, 30, 40 years behind every other industry, from everything from integrated information systems to really embracing some of the new technologies. Obviously not 40 years, but wireless is out. The old phones are gone. We have Dr. Steinhubel, who works for us now, is actually doing research around medical applications, wireless applications that we can use to keep people well and monitoring their health. Dr. Eric Topol is running our genomics program, et cetera, and he just wrote a book, and he's advocating hugely for nanotechnology and all sorts of wireless technologies where literally we can monitor patients remotely And of course, he's doing some studies now where he can literally detect a cell dropping off and predicting heart attacks and a variety of different things. That may be a ways off, but not that far off. So we need to harness technology. It goes back to the wellness piece. If we can actually monitor patients in their own environments, in their own homes, and interject and, medically before they need inpatient hospital care, it's going to be far less expensive. We're going to keep people healthier, and it's obviously going to be better for everyone. So we're investing in that technology in a big way. A lot of the major organizations around the country are doing the very same thing, and I think that's going to be a way of, again, creating a more healthy environment at a much lower cost.
In some of the Scripps materials, I read that you talk about horizontally matrixed management.
Yeah.
I was really curious what that means.
Well, that was our step towards becoming a much more integrated and effective organization. When I came to the organization, we were not doing well economically, and I took over right after votes of no confidence from our medical staffs across the entire system. And my answer and solution at the time was to completely decentralize our system and put both accountability and decision-making really back to the bedside. And we really did a good job with that, and each of my hospitals did a very, very good job, but they did it differently. They actually created variation, and of course looking forward, knowing that we have to be more integrated and a much lower cost going forward, I was actually in the Papal Nuncio's compound in Haiti, looking down on Port-au-Prince with our medical response team, thinking one morning how pretty it looked. And then I caught myself going, oh my gosh, this is not pretty. There's 250,000 people buried in homes down below. But I said, that's how we look at our healthcare system today. And each of my hospital chief executives are wonderful. They're the best in the business. But they thought they were the best practice by the way they operated their hospitals. So when I came home, I said, I wonder if we sliced our system horizontally, what we would see. And just between our 5 hospitals, we saw $150 million in operating variation. Variation in quality, variation in staffing, variation in supply use. Well, the first path then to reducing cost, and we have a philosophy against doing layoffs. I believe that a layoff is an absolute management failure. So what we said, if we're going to lower cost, we need to get the waste out of the system and the variation out of the system. So frankly, what I did is I flipped the company on its side. I took all the chief operating officers out of their hospitals, and for the first time, instead of giving them a silo responsibility, I gave them a responsibility for a function like imaging across the entire continuum of care, all of the hospitals and the ambulatory environment. And their charge was to identify variation in the practice and system, working with the management teams in the vertical places, who are absolutely critical because they're the ones delivering care every day, working together in a matrix way to take the waste out, improving quality, taking out cost, not laying people off. And in the last 3 years, we've taken $200 million out of our operations, and that's been validated by a number of our finance people, without laying anybody off. And by the end of this year, we had a $97 million goal this year. We're going to succeed on that goal, so it will be $300 million by the end of this year. And I've targeted another $300 million over the next 3 years. And that'll make us very cost effective, much higher quality, and much better for the patients because it'll be a lower cost of care.
That was a really interesting description. Just to sort of take it back to Tri-City, which is still struggling, if you were to look at the way that district is functioning and the fact that the hospital needs earthquake upgrades that are going to be massively expensive, and the taxpayers already said a couple of times they don't want to pay for it, what would you do under those circumstances, bearing in mind you say a hospital is essential?
Well, let me just say, Tri-City is an excellent hospital. I mean, we know a lot of the doctors and the staff that work up there. It's a great group of people. So their challenges, frankly, have nothing to do with the quality of the people that work in that hospital. They deliver excellent care. So their challenge, again, is that they're in a standalone hospital that has limited resources and the ability to replace themselves. The most expensive unfunded mandate probably in the state of California was the SB 1953, the Seismic Safety Act. Very, very expensive. Even at Scripps, I have to replace all of our hospitals before 2030. Now, we're okay to 2030, but it takes years to build a new hospital, and that's why we built up our financial strength. That's part of the reason I want to lower the cost of care, so we have enough resources to replace ourselves. Tri-City is going to have to do the very same thing. Now, they were effective at getting the extensions that they needed to get, so they have time, and there still is time. But they're either going to have to generate the revenue themselves to be able to replace themselves, or they're going to have to partner with somebody that can help them do that. And that'll be the choice that they have to make.
For the Scripps system, what's your next pieces of building? Where do you build? What do you build?
We're focusing a lot on replacing what we have. So, for example, in the next few weeks, we will open our new critical care and emergency room at Scripps Encinitas. Next March, we'll open up the new Prebys Cardiovascular Institute on the La Jolla campus. We just finished a replacement of a trauma and ED center down at Scripps Mercy Hospital. So probably our next big hospital move is going to be at Mercy San Diego. That's an inner city safety net hospital. It needs to survive, and we need to replace it, so we're going to start that process. And then at the same time, we're focusing a lot on purchasing property and building ambulatory sites. When I came to Scripps, we had 5, 6 ambulatory sites. Today we have 25, and we've purchased property to do more because, again, in this new model of care, we need to be close to a patient's home, but not with a hospital. We need to be an ambulatory site, so we'll be building a lot of ambulatory sites.
Is that like when Scripps obtained Scripps Coastal? Isn't that what it's called? Scripps Coastal
Yeah,
Medical
Scripps Coastal
Clinic?
Medical Group,
Yeah.
right?
Is
Yeah.
was that where you
That's-
basically partnered with an existing group and absorbed them?
What they did is they joined our medical foundation. So it is an independent group in the sense that it's, we have the corporate practice medicine laws in California, so we cannot employ physicians.
Right.
So all the doctors work for the medical group, but we own the infrastructure in which they practice, and so we can become fully integrated in that way. So yes, those sites are part of our 26 ambulatory sites. We have small sites that are just really doctors' offices, and then major ambulatory sites with ambulatory surgery and complex imaging and all of those things. And again, far less expensive to build an ambulatory site because that actually falls under the building codes of the city and the county versus a hospital. California, to build a tertiary hospital, it costs $3 million a bed. 3 times more expensive than any other state in the country because of the regulations and the seismic requirements for building hospitals. So the future of healthcare in California is not building lots of big hospitals. It's delivering care in a less expensive place to do that, but then having hospitals, obviously, to take care of the sickest of the sick. And there's going to be some regionalization of care and some of that along the way as well.
I've been speaking to a couple of people who were very concerned about the state of the hospice industry in San Diego, especially after the recent big changes where the San Diego Hospice had to close. And you have a hospice. I mean, what is your commitment to hospice, and how difficult is it going to be financially to really keep that kind of service around?
That may be one of those services that the rest of our operations have to subsidize. It's extraordinarily difficult to comply with all the rules and regulations that have been set up and generate a margin from hospice. The reason we had never had a hospice, and the reason we didn't, is because San Diego Hospice met all of the community needs, and we've never believed that we should be duplicating resources that already exist in the community. They came to us actually before they went bankrupt and asked for our help, and there was really not much we could do. They had a legal issue with the government that was not something we could solve or they could solve. So what we did is we bought a small hospice, Horizon Hospice, because it takes about a year or 2 to get a license in California. And that created a vehicle for us to be able to take a lot of those patients to make sure that their care was not interrupted. And that was we actually hired the nurses, so the care was never interrupted. And we're fully committed to hospice.
Thank you very much. It's been a very interesting discussion. That's all the time we have for in this segment, Mr. Van Gorder. Stay with us, and we'll be back with Jerry Kern in just a minute.